Hello everyone and welcome back to This Week in Pulmonary and Critical Care Medicine. Every week I'll take you through a few key studies that matter for our practice, plus one review article you might want to keep for your weekend reading. Remember, this podcast is for education only, it's not medical advice, and management decisions should always be tailored to your patients and your local protocols. This week we'll cover the new ATS guideline update on community-acquired pneumonia, the HOPE trial on late window thrombolysis in ischemic stroke, a pragmatic trial design called ABDOPOCUS-HF that combines intra-abdominal pressure with point-of-care ultrasound to guide decongestion in heart failure, and finally a fresh meta-analysis on whether we still need antibiotics in cirrhotic upper GI bleeds. We begin with the ATS guideline update for community-acquired pneumonia published in the American Journal of Respiratory and Critical Care Medicine this July. This update is focused on four common but clinically tricky questions. Should we be using lung ultrasound instead of chest X-ray? How do we handle antibiotics when a viral pathogen is detected? What's the optimal antibiotic duration once the patient is stable? And when should we reach for corticosteroids? The panel reviewed evidence systematically and issued graded recommendations. First, on diagnosis, lung ultrasound is considered an acceptable alternative to chest X-ray if you have local expertise. Meta-analyses showed sensitivity close to 95% for ultrasound compared with about 70% for chest radiographs, although much of that evidence is indirect and operator dependent. So if you or your colleagues are trained in lung ultrasound, it's reasonable to use it as the first imaging tool, especially when access to radiology is delayed. On the question of viral positive pneumonia, the guideline suggests withholding empiric antibiotics in outpatients without comorbidities when a respiratory virus is detected. But if the patient has comorbidities, or if they are sick enough to be admitted, the recommendation still leans toward empiric antibiotics because of the risk of bacterial co-infection. That's very low quality evidence, but it does support antimicrobial stewardship in healthier outpatients while keeping a margin of safety in higher risk groups. Next is antibiotic duration. For non-severe pneumonia, both outpatient and inpatient, the panel recommends less than 5 days, with 3 days as a reasonable minimum if the patient is stable and improving. For severe pneumonia, they recommend at least 5 days, a reminder that undertreating here can have serious consequences. Finally, steroids. The guidance is strong against routine corticosteroids in non-severe community-acquired pneumonia, mainly because of harms like hyperglycemia. But for severe cases, they conditionally suggest steroids, with the important caveat that this does not apply to influenza pneumonia. In short, the message is clear. Think about ultrasound when you can. Avoid reflexively giving antibiotics to low-risk viral outpatients, keep courses short once patients are stable, and reserve steroids for the sickest. Importantly, this update was approved by the ATS, but not yet by the IDSA, so adoption may vary by institution. Our second study shifts gears to neurology, however, is still directly relevant for intensivists. The HOPE trial, published in JAMA this August. This trial asked whether alteplase could benefit ischemic stroke patients who present well beyond the conventional 4.5-hour window, in fact up to 24 hours, provided that perfusion imaging showed salvageable brain tissue and no thrombectomy was planned. 372 patients were randomized across 26 centers, half receiving intravenous alteplase and half standard care. At 90 days, 40% of the alteplase group achieved functional independence compared with 26% in the control arm. That's a relative increase of about 50% or a 14% absolute gain. Mortality was identical, 11% in both groups. The main downside was symptomatic intracranial hemorrhage, about 4% in the alteplase group compared with 0.5% in controls. So what do we take from this? For carefully selected late presenters, alteplase can meaningfully improve independence without raising overall mortality, though it comes with a real hemorrhage risk. This aligns with the idea that treatment should be imaging guided, not purely time-bound. A practical note though, the study was done exclusively in China and used alteplase, not tenecteplase, which many centres now prefer operationally. Still, if your hospital sees patients outside the window and thrombectomy isn't planned, this trial supports offering thrombolysis when perfusion imaging shows salvageable tissue. From neurology, let's move to cardiology and critical care with the ABDOPOCUS-HF trial protocol, published online in ESC Heart Failure at the end of July. This is an intriguing attempt to operationalize decongestion in acute heart failure. We know that congestion drives readmissions and mortality, yet our tools for monitoring it, daily weights and physical exams, are crude. This study randomizes 168 patients across 14 Spanish hospitals to standard diuretic care versus a strategy guided by intra-abdominal pressure combined with point-of-care ultrasound. That ultrasound bundle included lung B-lines, IVC measurements and Vexus scoring, with baseline intra-abdominal pressure measured through the bladder. The primary outcome is resolution of systemic congestion at 72 hours using the ADVOR score, a clinical tool used to measure the severity of fluid overload in patients with acute decompensated heart failure. Secondary outcomes include pulmonary congestion on ultrasound, biomarkers like NT-proBNP, total diuretic dose and efficiency, length of stay, and then hard outcomes like death or rehospitalization at 30 and 90 days. Safety outcomes are important too, including renal function, electrolytes, and catheter-related infections. This is only the protocol, results aren't out yet, but the design itself is pragmatic and forward-looking. If positive, it would encourage teams to shift from vague clinical impressions of congestion to structured, reproducible, physiologic targets. The hurdle, of course, is measuring intra-abdominal pressure, which requires catheterization and nursing support, and not every team is familiar with the ADVOR score, so bedside uptake may be patchy. Still, this kind of approach could change how we think about venous congestion in the first 72 hours of hospitalization. Finally, our review of the week comes from JAMA Internal Medicine, published on August 11th. It tackles a long-standing reflex in cirrhosis care, giving 7 days of antibiotics to every patient with an upper GI bleed. The authors pulled 14 randomized trials with more than 1,300 patients, most of whom had varicose bleeds. Using Bayesian methods, they tested whether shorter antibiotic courses, or no antibiotics at all, were non-inferior to the standard 5 to 7 days in terms of mortality. The probability of non-inferiority for mortality was over 97%, with a risk difference under 1%. For early rebleeding, the probability was about 74%, though confidence intervals were wide. Infections were more common when antibiotics were shortened or withheld, but definitions were inconsistent and often not clearly linked to the bleed. So what do we do with this? The historical mortality benefit that justified blanket prophylaxis is not supported in contemporary practice. A more nuanced approach seems appropriate. High-risk patients, such as Child-Pugh C, those in shock, or those with poor source control, may still deserve short, targeted prophylaxis, but it's difficult to justify routine 7-day courses for everyone. In practice, a 24 to 72-hour course around endoscopy and vasoactive therapy may suffice for many patients, especially if hemostasis is secured and local bacterial resistance patterns are unfavorable. The bottom line is that the reflexive ceftriaxone for a week in every cirrhotic bleed is worth re-examining. And that wraps up this week's roundup. To recap, the Community-Acquired Pneumonia Guideline update gives us permission to use ultrasound, where we have expertise, to shorten antibiotics and to reserve steroids for severe cases only. The HOPE trial expands thrombolysis safely into the late window, and imaging supports it. ABDOPOCUS-HF might, if positive, bring structure to decongestion strategies in acute heart failure. And finally, our review suggests it's time to rethink routine antibiotics in cirrhotic GI bleeds. Thanks for tuning in. If you found this helpful, consider sharing it with your ICU or pulmonary colleagues and subscribing for weekly updates. I'll see you next week with more data that matters.